From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Tuesday, the 13th of August, 2024. Over the past few months, since the FDA issued its final rule on regulation of laboratory developed tests, there have been a lot of questions swirling throughout the clinical laboratory community about how the new rule would affect laboratory operations, but more importantly, how it might affect patient care. And so for today's LabMind episode, we have solicited your questions using both our email lists and social media posts, and we're going to try to answer as many of them as we can. And by we, I actually mean Dr. Jonathan Genzen, Chief Medical Officer and Senior Director of Government Affairs at ARUP Laboratories. Let me also say, if you have not yet watched Dr. Genzen's webinar on the FDA LDT rule, you can easily find that by searching on YouTube, and we will put a link in the show notes. In addition to his executive roles at ARUP, Dr. Genzen is Professor of Pathology at the University of Utah. He received his medical degree and PhD at the University of Chicago, followed by pathology residency and research fellowship at Yale, and subsequently an MBA at Cornell University. John Genzen, welcome back to LabMind.
Thank you very much. It is absolutely great to be here with you today.
So I want to dive into the questions that we had sent in. But first of all, let's just say that they landed in several different categories. So there were a few questions about the legal aspects of this and Supreme Court action that could cast nuance on that. The largest category of questions, though, turned out to be pretty specific technical questions. For example, flow cytometry, as I understand it, is exempted under certain circumstances, but people were wondering if their particular circumstances would apply. When we talked about this in preparation, you said you wanted to be a little bit careful about answering really specific technical questions. So what's your thinking on this?
I'm glad we're starting with that. I would say at the onset, we're going to talk about some issues that are legal. I am not a lawyer. I just want to be very clear about that. If people have specific legal advice related to their testing or the strategies that they're thinking about following, they need to pursue appropriate legal counsel and talk to their compliance groups. Also, that second bucket of technical questions, a lot of these are questions that only the FDA can answer. So I'm happy to share some perspectives and share my thoughts on certain issues, but it really is the FDA that can provide definitive guidance. They've got an email address, LDT final rule at fda.hhs.gov. We can include that in the final notes as well, where they're soliciting questions, but they've yet to provide a lot of clear guidance on some of these common questions that people have. I would encourage people to submit questions that way, but we'll obviously talk about a lot of these issues, and I'm happy to share my opinions, but they are just opinions, and I want people to keep that in mind.
It does feel like the final rule left open a tremendous number of questions. So I just wonder how many of these questions are going to be coming into the FDA.
I would hope that the FDA starts responding to many of these types of questions that they're receiving, because labs are going to need clarification if they're going to plan appropriately. That being said, I suspect many of these types of questions may be left for labs to figure out along the way. And that's an unfortunate consequence if there isn't draft guidance provided.
So one category of questions had to do with the role of the New York Department of Health, which is actually pretty interesting. I don't know of any other precedent for a state level health authority playing this kind of a role in an FDA or a federal healthcare level regulation. So Stephen, for example, asked about the significance of the New York exemption category and why it exists in the first place. What's your understanding of the role of New York in this whole LDT regulation?
That's a fantastic place to start. There have been a lot of questions about New York because of how prominently New York was mentioned as one of the partial exemption categories within the final rule. Personally, I think there was actually significant political pressure circulating around the VALID Act at the time about making sure that New York had an appropriate exemption as part of what the final VALID Act might have looked like. The VALID Act didn't pass. And so I think maybe some of that perhaps carried over into the FDA's final rule to maybe address some of those concerns that legislators from New York had at the time. I would say at a very practical level, the New York Clinical Lab Evaluation Program has a long-standing history of quality and a long-standing history of LDT reviews. So it does make sense to incorporate what New York has been able to accomplish into whatever final rule or legislative solution that's out there. Practically as well, I would say that New York submissions have far less administrative burden versus FDA submissions, but also it lessens the burden of the FDA's final rule on the FDA itself for New York accredited labs. So there's probably a practical reason why they included it as well. I would say, ironically, it also provides evidence that the FDA has acknowledged that a CLIA framework for LDT reviews can work. It's peculiar that it's restricted to New York State and VA hospital and Department of Defense laboratories, for example, but it is evidence that they acknowledge that that framework can work and that they're okay with that framework from New York State in particular.
So what's so special about New York versus, say, I don't know, Nevada?
That's another good question.
New Hampshire?
Yeah, the New York Clinical Lab Evaluation Program and the New York Regulation of Clinical Laboratories, to my understanding, actually predated CLIA. And so that structure for clinical lab oversight had already existed and has existed for a long time. And they actually addressed within CLIA that framework for what to do about laboratory developed tests way before the FDA ever considered doing that. So the infrastructure already existed, and it exists within the New York State regulations. It is an official process that New York has established that's been longstanding, that most other states have nothing similar, which is why New York is pretty unique in that way.
Is it conceivable that another organization could create an accreditation program that FDA might fold into their rule long term?
The FDA has a third-party accreditation program that can be used for submission and review of some moderate risk medical devices, but it's a different structure and a slightly different purpose than what New York does. It's my understanding that New York actually used to be one of these FDA third-party accredited agencies, but they no longer serve in that role. I think the FDA has, and they've said this in the final rule in some of their public statements, that they anticipate that their third-party review program could offset some of that work that would be hitting the FDA with the large number of submissions that would have to occur as part of the final rule. What's kind of interesting about that, though, is the third-party review program has actually not been used much for in vitro diagnostics. Very few IVDs have been submitted as part of that program. And I don't still have a good understanding of why that is. But I do say that to say maybe it's unrealistic to expect the third-party review program to carry all this work if most people really haven't been using it to date anyways.
So is this a program for just the medical device side of FDA or devices and pharma?
My understanding it is for devices, but that's all categories of devices as long as they're considered an eligible device category. I don't think it works for pharma. I'm not 100% sure about that, though. What's interesting, though, is it's not reducing the work that laboratories have to do as part of the final rule. It's just redirecting that review process to a third-party reviewer who then submits their recommendation to the FDA.
So that is a little bit different than New York, correct?
Yeah, absolutely. And people also need to be aware with New York, you have to be a New York accredited laboratory to submit an LDT to New York for review. And that has its own cost-benefit analysis. It really only works if you are actively taking care of specimens from patients from New York. That's where that accreditation is actually required. And the New York exemption category, it doesn't eliminate everything as part of the final rule. You still have to comply with stages 1, 2, and 3. What you don't have to do if you get New York approval is then submit your test for FDA clearance or approval as part of stages 4 and 5.
So we had a question from Mari asking whether the New York process is less burdensome than the FDA process and whether smaller organizations, for example, might find it easier to go through the New York process rather than specifically FDA pre-market approval. Any thoughts or guesses on that?
Yeah, maybe we'll talk about some of the similarities and differences. Under both New York, the existing system and what the FDA is proposing and what's finalized as part of the final rule, for new tests, according to the stage guidelines and the final rule, you'd be submitting tests for review before they go to market. So in that sense, they're similar, but there are some pretty significant differences too. I would say, maybe this is another similarity, for New York reviews, the applications are thorough and the reviews are thorough as well. It's a well laid out process with information that you have to submit to New York. It is less costly, at least currently, than FDA pre-market submissions because the current costs for New York submissions, I believe, are covered by your laboratory permit, and it's not a separate application fee. Now, it's hard to imagine that's going to be sustainable if the FDA final rule holds. I would suspect that New York would be thinking about how they may need to structure their program going forward, so it's entirely possible they could have some changes there too. I would say we've had a lot of experience submitting to tests to New York. It's an outstanding group of reviewers. They deliver high quality reviews. It is less administratively burdensome than what I would anticipate the FDA reviews would be. So there are some advantages, at least under the current structure, to submitting things to New York. There are some key questions here, though. Would New York actually have the capacity to handle a significant volume of increased submissions? Would they have to change the cost structure? Would they have to adapt their staffing? I'm sure they're thinking about a lot of issues and how they're going to adapt, and probably watching carefully the status of the final rule and whether it withstands litigation before they consider making any dramatic changes. That's at least would be my guess.
So let's shift gears a little bit. There were a number of questions about the political and the legal side of this. First of all, Stephanie and Mike both submitted questions about the implications of a recent, rather famous Supreme Court decision. Mike's question reads, with the Supreme Court overturning the Chevron deference ruling, does the FDA even have the authority to make decisions concerning expansion to its jurisdiction without Congress specifically stating it can do so? Any insights on this?
Yeah, so there have been two recent Supreme Court cases that do have some bearing, I think, on the LDT issue, but all federal regulations. The most recent of those was the Chevron deference decision. So Chevron deference was this idea that the courts held for decades that if a law was ambiguous, a law passed by Congress, that the courts would defer to an agency for clarity on that ambiguity. And the recent Supreme Court ruling, and this is, my layperson interpretation, but the recent Supreme Court ruling overturned that principle. And that basically means if a law is ambiguous, it's up to the courts in Congress to primarily sort out that ambiguity, not just defer to a federal agency. Now, they're supposed to still take that feedback and expertise from the federal agency, but not defer it. The other one that's gotten a lot less attention is called the Major Questions Doctrine, which was decided, I believe it was 2 years ago. And that's somewhat similar. If an issue has major political or economic significance, can an agency just decide for that on their own? And that ruling basically said, no, Congress has to decide issues of major political or economic significance. So why do these have an impact on the FDA final rule potentially and other issues from federal agencies? When we think about LDTs specifically, I think there really is an impact because the FDA authority over LDTs at best is ambiguous. And more likely than that, probably not supported by prior laws, including the medical device amendments, which were passed in 1976. And I say that because laboratory developed tests were never discussed, as far as we can see, in any congressional deliberations prior to the passage of that law. And they're actually not even discussed within the law itself. On top of that, the FDA never acknowledged for 16 years that they even knew of the existence of laboratory developed tests. So for the FDA now to say they've had enforcement discretion over LDT since 1976, it just doesn't feel like it's supported by law, and it's ambiguous at best. So in that sense, I could certainly see why somebody would try and apply the recent Chevron deference ruling thinking about LDTs. Now, Chevron deference may not be the core issue associated with litigation against the FDA final rule, but at the same point, it is of such national significance that I would suspect any court case would kind of have this in the back of their mind, or any judge may as well.
We had a question from Deborah asking about the implications of any lawsuits against the FDA. What's the status of any such lawsuits?
Yeah, so as of today, when we're recording this, there's been one lawsuit filed from the American Clinical Lab Association against the FDA final rule. There may be others, and we'll watch to see what happens on that front. Any litigation around this, however, is basically following the same process. It's litigation associated with the Administrative Procedure Act. That's the federal law that describes how agencies can roll out new federal regulations and whether they followed that right, and whether an agency even has the authority to do what they've rolled out within a new regulation. These cases, in my understanding, is they tend to move a little bit faster than some other types of lawsuits because the evidence is what is already included as part of the public record created to that rulemaking. So there's not an evidentiary phase for the most part as part of these lawsuits. So generally speaking, 1 to 2 year time frame maybe would be reasonable with this type of case. What's really relevant for the clinical lab community is with the current litigation, would we see an outcome prior to the stage 1 requirements, which will be May 6th, 2025. So we're all watching that carefully because the outcome of litigation could potentially change what labs do or don't have to do. It's probably important for me to clarify. I am very supportive of the ACLA lawsuit against the FDA final rule. I've written and provided a declaration letter as part of that lawsuit. So I'm not a plaintiff, but I'm very supportive of that. And I think audience members, people listening, should at least know that it definitely influences my perspective on litigation.
And ARUP Laboratories is a member of ACLA, correct?
Yes, that's correct. All of that being said, the final rule has the full force and effect of law currently. So we are obligated to comply with this because it's essentially law, even though it was developed through a regulatory process instead of from Congress. So what's the impact of that? What should labs do? I think it's common sense that labs should start preparing for stage 1 requirements. Those are the first requirements that are due, and really start educating and preparing for stages 2 and beyond if the final rule stands. Some of the stage 2 and 3 requirements in particular, so for stage 2, the labeling requirement, and stage 3, the quality management system and design control requirements, those are pretty heavy lifts, and they're going to require significant advanced preparation. So they're not things you can just start a month before the deadline and comply appropriately. So I think now is the time to start understanding what are in those requirements. What would you have to do as you start planning for these going forward? So start preparing and be strategic about how you apply resources so that you are applying resources in ways that you can afford and that meet this adherence strategy going forward as well. Stage 1 isn't the problematic stage. It's just the medical device reporting, complaint files, and corrections and removals. And those are doable. They're not going to require significant investment in infrastructure, some policies and procedures and knowing what to do. So start preparing for those. That just makes sense.
So we also had some questions on the political front. Mari asked, there have been recent articles and in mid-July, according to an AMP group, Association for Molecular Pathology, the House Appropriations Committee was issuing bill report language to direct the FDA to suspend its efforts and continue to work with Congress to modernize lab regulation. Any thoughts on the political front? Do you think that House of Representatives is going to force the FDA to revisit any of this?
There is language that's included in the draft appropriations bill that came out of the House Appropriations Committee that is asking the FDA to essentially not move forward with this final rule. That language, however, is non-binding. It's not a part of the bill in a place where it is an obligation on an agency. It's just a recommendation. And these are very commonly provided where maybe a committee wants to share a perspective but not make it a requirement. So keep that in mind. It is non-binding. The FDA doesn't have to follow this recommendation. I would say federal agencies rarely do, and certainly rarely do when the language is coming from a committee that has a majority from the opposing political party. It's often a chance to send messages. But it's good from an advocacy perspective. It does share, to some extent, a perspective on congressional intent. Certainly, if it makes its way into the final appropriations package and is passed by both houses of Congress and both parties, you can use that as a message of congressional intent, but it is non-binding. There's also been a lot of conversations about the VALID Act, and there have been a few members of Congress who solicited some additional questions and are trying to get additional perspectives and information. I would say it is exceedingly unlikely that there is a legislative vehicle this year that could move the VALID Act forward. I think in many ways, people are waiting to see what happens with the litigation and probably the next Congress to see what to do next. And that would obviously involve who is controlling both houses of Congress as well. So that's also in play here too.
So separate from ACLA, has ARUP had any engagement with Congress over this issue?
Absolutely. We've provided public comment letters at each stage along the way. not just with the Valid Act, but also related to the FDA final rule. Being engaged is incredibly important right now. And I would say that is true for any clinical laboratorians and anybody who is interested in this issue. Understanding how Congress works and certainly understanding how to communicate with your legislators is incredibly important. A great example of that, we had the awesome opportunity a month ago to host a congressional field hearing for the Ways and Means Committee. And that's not the committee that has oversight over the FDA on this issue, but it was an opportunity. We had 10 members of Congress come to ARUP and sit in a clinical laboratory during this hearing and to see the amazing work that clinical laboratories do. So any type of engagement, I think, is positive here so that members of Congress and regulators have the opportunity to see the good work and not view the LDT issue as one of the FDA perspective where they convey that patients are at risk and patient harm, but rather see the amazing work that's ongoing every day from the over 100,000 laboratory professionals who work across the country to do this high quality work. The other thing about that field hearing is it did give us the opportunity to submit comments where we were able to put within the congressional record our concerns about the FDA final rule, as well as our concerns about the PAMA clinical laboratory reimbursement cuts and the impact that that's going to have on the community as well.
So, notwithstanding your disclaimer at the beginning about needing to be a little bit careful about answering questions that the FDA really needs to answer at their end, let's just try a few technical questions that came up in our responses and see if there's anything that can be said about them. We have a question from Heather asking, the rule says that histocompatibility testing related to organ transplant is exempt, but what about HLA testing that is not for transplant, such as HLA-B27 for ankylosing spondylitis and other disease risk?
Yeah, my understanding is the non-transplant HLA testing is subject to the same requirements under the final rule, just like any other laboratory developed tests.
And then we had a number of questions that had to do with, is it an LDT or isn't it? In particular, when modifications are made to an FDA-approved test. So one example is validating body fluids for an assay where the manufacturer has validated it for, say, serum, maybe urine, but not other body fluids. And then the laboratory can perform matrix studies to demonstrate comparability to serum and that sort of thing. So does this make it an LDT? What's your understanding about where the boundaries around that are?
Yeah, so there's discussion about this within the final rule, and I'm happy to share what my understanding is, but I would also refer people to the final rule as well to make their own interpretation. To some extent, the requirements depend upon the extent of the modification and whether that necessitates a pre-market submission, which would be the stage 4 and 5 requirements. First of all, I think the FDA is saying any test modification makes it an LDT. The question, though, is do you or do you not have to submit a pre-market submission to the FDA based on that modification? And they kind of divide this out into minor modifications and then more specifically, types of significant modifications that would necessitate a resubmission. So they include things like changes in indications for use, changes in operating procedures, different technologies, or switching from a manual test to an automated test as things that require both stage 4 and 5, the submissions, but also require the quality system regulations as part of stage 3. So getting back to the original question, my understanding is a change in fluid type from like a serum plasma to a body fluid, if you're putting it on your test menu and you're marketing it in that way, is a change in intended use, which would be considered significant and would require submission to the FDA. It's interesting, the FDA doesn't place the same restrictions on clinicians who can order and use a test for whatever purpose they want, as long as it's part of a legitimate provider-patient relationship. So they did create this distinction. They talked about this on their webinar, explaining the final rule about a week or so after it was released. So I think body fluid validations, which is the original intent of this question, it's a really tricky thing here because the FDA, I think, is saying you have to submit them, but I personally think it's something that's best kept under CLIA and not the FDA, because there really is no volume or financial justification to ever support an FDA submission for testing that is of such low volume and used so rarely. So I hope there's additional guidance and clarification at some point, but I'm not sure we'll get guidance to that level of detail. The FDA has said, however, they do anticipate releasing guidance on maybe some common forms of modifications, things like changes in specimen stability, because perhaps the feedback has sunk in a little bit that perhaps there is little value in economic sense to reviewing things like that, as long as they're validated, shown to be done appropriately. But that guidance is not out yet, so we don't know what it will or may look like.
And you mentioned automation. There are a number of different aspects of a test that theoretically could be automated. You mentioned automating a previously fully manual test. What about automating some of the specimen preparation, where the later steps of the process follow the FDA approved kit, but maybe you've done some liquid handling or something at the front end? I mean, where are the boundaries around that, do you see?
I have no idea, to be honest, and the FDA is going to have to provide clarity on that front. They pretty much describe automation as requiring a pre-market submission, but perhaps that comes from not fully understanding the practical applications of automation across many, many clinical lab settings. Like you mentioned, their use in pre-analytic processing. We use automation extensively to prevent repetitive motion injuries from capping and decapping and maybe initial pipetting steps when you're preparing a plate, but you're not quite at the assay stage. That's really not described in the final rule, and I think labs need clarity. In my opinion, this issue with automation in the final rule is very bad for laboratory operations and bad for patient care because it incentivizes less automation, which promotes more repetitive motion injuries and more potential manual laboratory errors, the exact thing that automation is implemented to try and prevent. This is actually one of the big missteps as part of the final rule and one of my major concerns here as well.
That part did seem to jump out as a very curious aspect. I guess we shouldn't speculate as to why it was drafted that way, but it did seem curious that FDA would be specifically promoting older, more manual testing if there's alternatives.
I think it largely was to try and fit a framework into a lab testing domain rather than think about what the right framework could be going forward. There's many types of automation. Some of them probably legitimately are so complex, maybe they need additional layers of regulatory oversight, and some are so simple that it just doesn't make sense. Like when I think about automating an otherwise manual test, if you validate that manual test on automation and show that it performs exactly the same way, and that's what we already do under CLIA, what labs across the country are doing under CLIA, where is the added value for a tens or hundreds of thousands of dollars of an FDA submission fee to review that? It just doesn't make sense. But that's the way the final rule is currently written.
So there's also this issue about what things are grandfathered. So for example, Lori wrote in with a question asking, will LDTs that were developed before the final ruling took place be grandfathered in? And then what is the cutoff for these tests to be affected by the new ruling?
Another great question. There is this category for currently marketed laboratory developed tests, and that currently marketed category is what some people are calling grandfathering. I don't like that label because it's not a strict grandfathering where no regulations apply. The stage 1 and 2 requirements, for example, apply to tests that fall under the currently marketed pathway. I think the FDA established that currently marketed category because they acknowledged the tremendous harm to patient care that would happen if they forced laboratories to suddenly remove assays across the board. So I do support having a currently marketed exemption, but there are requirements that still apply and people need to make sure they understand those so that they comply with them appropriately. And the cutoff date was May 6th of 2024. So this past May 6th. So if your test was on your menu and you were marketing it before that date, you can keep your test on your menu as long as you don't significantly modify it and you fit that exemption category. So May 6th is the date people need to keep in mind.
And then it sounds like the term significant modification may turn out to be a sticky point.
Absolutely.
So let's suppose that there's a test, an LDT, that due to one of these exemption categories is not going to be subject to the full pre-market approval requirements. Is that a permanent state of affairs, or could that change at some point in the future where suddenly it is subject to pre-market approval requirements?
I'm glad you asked that because this is one of my other major concerns with the final rule and how it was developed. The final rule itself is just a 10-word addition saying, including when the manufacturer is a clinical laboratory. All of these other things we're talking about, New York, VA hospitals, currently marketed, unmet needs, all of that falls under this concept of limited enforcement discretion and basically saying the rules apply to everybody, but here are the categories where we're going to only apply some of the rules, but not all of them. Because none of that is codified, the FDA can change this at their will. It's not in the federal regulations itself. So just because they say your test is currently marketed today doesn't mean a year from now they can come back and say all currently marketed X type of tests now are subject to full FDA requirements and require submission. So there is a tremendous amount of leeway that the FDA is given to do this that creates uncertainty for clinical laboratories when you're trying to debate, where do I invest? What's safe to keep offering? What testing is going to require submission going forward? If you can't really 100% predict that, how do you plan appropriately? And I think that's one of the big limitations of the final rule. I would also layer on to that, there's some aspects maybe similar to that on the unmet needs provisions, where the moment that another commercial manufacturer has another test on the market that meets that unmet needs, all of a sudden your test doesn't meet the unmet needs provision and you would have to submit to the FDA if you were going to continue to do that. Right? That's an incredible burden on laboratories to not just keep track of that, but to logistically manage that and send out specimens or move patients between healthcare facilities, for example, to do appropriate testing. It is an unreasonable ask on clinical laboratories that I think genuinely has a negative impact on patient care. But the FDA has that flexibility to do that because, again, none of this is in the regulation. It's all based on enforcement discretion.
The last point that you just made makes me think that if I'm a laboratory and I'm trying to make a smart financial decision about whether to undergo the resource costs associated with pre-market approval, for example, that decision would be heavily dependent on the time period over which you amortize that expense. And if there's uncertainty about whether something could come along that would cause the FDA to change their mind, that could really mess with that decision making.
Yeah, absolutely. It's a very challenging situation for clinical laboratories, and definitely clinical laboratories that have limited resources, which is pretty much all laboratories, that I think there's just an incredible discordance between the resources that it will take to comply with the rule and the resources that clinical laboratories actually have. And certainly in circumstances like we talked about earlier with PAMA, where reimbursement rates are being cut and labs actually have less resources. So at the same point, one agency is decreasing reimbursement and yet another agency is increasing requirements that increase costs, right? That's not sustainable. It's not that hard to see that, but the question is, how will this adapt and will litigation be successful?
So on that note, we had a question that reads, I work in a small physician office lab with essentially a single LDT that was in use prior to May 6. We only test patients from our own providers. What do I need to do to comply with the final rule? I won't ask you to answer that comprehensively, but I think that's an example of what you're talking about. There are a lot of small clinical laboratories out there who may run one to a handful of LDTs, and to develop the whole compliance infrastructure and process to do this, that doesn't necessarily sound realistic.
There's a few points to that we can walk through. The first level is if you're running an LDT, it can only be run in a high complexity CLIA laboratory. So that has to be considered the baseline per CLIA regulations as well, and per the FDA's understanding here too. That description, a small lab running a highly technical LDT prior to May 6th, to my understanding, meets the currently marketed exemption category, which would mean that stage 1 and 2 of the final rule apply. And that may give the person who submitted that question a little bit of guidance. They may want to think about the unmet needs provision as well, because that may also apply depending on the type of testing that they're doing. And the unmet needs provision could have some advantages down the road if perhaps they need to modify their LDT. They would lose, if it's a significant modification, the currently marketed provision, but perhaps they could keep an unmet needs provision. So it's worth digging into those two concepts.
So this leads into a question about resources, not internal resources to the laboratory, but external resources. One question we received sort of jokingly asked if there was an LDT compliance for dummies that someone was working on publishing. Can you comment on any resources that you anticipate being available through ARUP, maybe through professional societies that you're familiar with? What assistance is likely to be out there for laboratories who need some help navigating this?
We, through our educational webinars and other products that we've been developing, have been trying to create a lot of material that people could use to understand what's in the final rule. So you'll see a lot of that on the ARUP website and what we've participated in and contributed to already. There's a lot of information from other professional organizations, including educational products and webinars, that are doing the same thing and that we're participating in as well. So I would point people to organizations they may already be members of, like ASCP, ADLM, and CAP are a few notable examples, AMP as well, where there are other products people can turn to learn a little bit more about the final rule. There is some practical guidance as well. CLSI, along with having a webinar, actually has standards that laboratories can use if they need to better understand how to validate. Some of these are FDA consensus standards or recognized standards that would basically be a guide to how to do a study in a way that the FDA kind of recognizes is the way that they're looking for. CLSI also has a crosswalk between some FDA requirements and CLIA requirements related to quality management standards that people may find useful as well. I haven't seen a single how-to guide, and I'd be honestly skeptical if I saw one because it is so complex. It's hard to imagine a single guide could accomplish this all. I am starting to see quite a few emails from consultants and external firms offering advice and services on how to navigate the final rule. Some of this may be very helpful to people. Some of it may not necessarily be as applicable in their settings. And labs would obviously need to be able to afford those consulting services, which is part of the financial concerns that we've had here as well. So there's a lot of information out there. We are transitioning from the what is in the final rule educational phase, that was the first few months, to now the what do you have to do to comply with the various stages? And so everybody's focused on stage one, and many of the professional organizations I mentioned and ARUP will have future offerings related to how to comply with stage one so that this is less difficult of a concept to think about because stage one is pretty manageable, but you have to kind of walk through the steps to understand what's part of it. So there'll be a lot of information forthcoming about that.
So stay tuned. So there were some questions specifically asking about what kinds of assistance ARUP might be able to support going forward. Anything to add to what you've already said?
Yeah, absolutely. Our goal at ARUP is, and I would say it has always been, to support testing being performed locally because that is in the best interest of patient care. You get an answer faster, you get an answer with local expertise with somebody who knows the patient. That is our priority. Unfortunately, the final rule does make local testing of LDTs harder and more expensive in the future. Now, not currently because you've got the currently marketed provision, but this really starts to hit about 2 to 4 years from now when labs decide should they or should they not be continuing with certain LDTs. That is the main reason why we've tried to stay at the forefront of advocacy on this issue, so that legislators and regulators in the FDA can better understand some of the unintended impacts of the proposals. And we are incredibly committed to supporting the needs of hospitals and clinical laboratories going forward to support LDTs. Kind of like what I alluded to earlier, the goal of our educational efforts has really been to understand what's in the rule and then understand how to start complying with the rule, and we'll continue with that going forward. I am very worried, though, that some health systems and maybe certain C-suites may make reactionary decisions based on what they're seeing in the final rule in the media. And so we're hoping that some of these educational efforts will help better inform laboratories and health systems so that maybe they can be a little more strategic and forward thinking about how they're going to adapt.
Okay, last question, and this is sort of my daydreaming question here, but I saw in the news recently that Jeff Shuren, who has been FDA's chief regulator on the medical device side of FDA for actually a large number of years and presumably had a large role in this whole LDT thing, just announced his retirement. So in my fantasy world, they would be calling you to step in, and that's probably not where your career trajectory is going. But if you had the ear of whoever ends up replacing Jeff Shuren, if you had the ability to influence the next generation of FDA leadership in thinking about laboratory tests, what would be sort of your key points that you would like to share?
So it's definitely not going to be me. They're not going to ask me because of my advocacy on this issue. But I'm kind of glad you asked it because I have been thinking about this a little bit since I heard that news. I would hope they consider engaging and bringing in somebody with many years of experience working in a clinical laboratory, certainly to be leading this initiative, because what they really need is somebody who understands the practical clinical lab dynamic along with the FDA regulatory framework. They've got to bring that in together. And this could be one opportunity to do that. I actually do, this may sound odd, I actually think there's an ideal solution. And I've mentioned this in prior conversations with regulators, with the FDA, with legislators, and I don't seem to be getting any traction on this. So this could be my opportunity to talk about it. It is this idea of an FDA CMS CLIA compromise solution. So what does that really mean? It means, number one, you keep the really simple stuff under CLIA because it's worked well there. It will continue to work well there. It allows labs to act quickly when they've got instrument downtimes, when they need to do emergency validations, when they've got supply chain shortages. You need ways to allow laboratories to do that fast and under the right and the safe framework. So keep that under CLIA, certainly the simple stuff. I would also keep the test modifications, most of them under CLIA as well. Specimen types, stability, tube types, automation is part of that. Like I mentioned earlier, there's really no practical benefit to FDA oversight here. Keep it under CLIA. It works well there, and it's cheaper. It's better for everybody. It's lower cost and great quality. I also support transparency. There could be greater transparency under CLIA on what LDTs are out there and what their performance characteristics and specifications are. Laboratories already have that information. They already collect it. If you're New York accredited, you're providing that to New York. If you're CAP accredited, you're keeping your list of LDTs on site. But CMS doesn't compile that or share that with the public. That's not a lab problem. That's an organization of information problem. And that could easily be fixed under CLIA and create transparency there too. But I think there's also a role for some of the really more complicated stuff, the higher risk stuff, having some degree of FDA oversight. I think it should be IVD and LDT specific. You shouldn't just lump it in with all medical devices and have the same fee structure. Certainly when you have institutions that can't afford that fee structure. But I think this is accomplishable. I mean, in that, 2 or 3 minutes that I've talked about this, there's some core principles that easily could be adapted into any future legislative or regulatory efforts. But it needs people who are willing to compromise. It needs agencies who are willing to work together and share that work because it is in the best interest of patient care and the American public to do that. That shouldn't be that hard, but it's been hard to get to that point. But I'm still optimistic we can get there.
Amen. John Genzen, thank you so much for coming on LabMind and offering a bit of clarity to an admittedly still quite murky area. I'm sure we'll have you back again.
Happy to come back anytime.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta-Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.